When people say they have rheumatism, they usually mean any chronic pain or stiffness in the joints or muscles, pain that worsens with cold, fatigue, or age. But in medicine, rheumatism is not one disease, it is a group of over 200 disorders. The most common one is osteoarthritis, also called degenerative joint disease, which causes more than half of all chronic joint pain worldwide. When people complain their rheumatism gets worse with age or weather, in about 80 to 90% of cases, it is osteoarthritis. After 60, 1 in 3 women and 1 in 5 men have it. Our joints wear down silently over the years. Every step presses the cartilage with several times our body weight. In youth, cartilage absorbs this like a sponge, smooth and elastic. With age, repair slows, and destruction outruns regeneration. Low inflammation begins, and the bone underneath thickens, forming bony spurs called osteophytes, the hallmark of osteoarthritis. Pain worsens with movement and eases with rest. Morning stiffness lasts under half an hour. The swelling is mild, and joints rarely get red or hot. Over time, the fingers become knobby, Heberden's nodes at the tips and Bouchard's nodes in the middle joints. The first few movements after rest hurt the most. This is start-up pain. The most affected joints are the knees, hips, spine, neck, and hands. Knee pain starts with climbing stairs or standing after sitting. The main risks are age, excess weight, old injuries, and genetics. Every extra 5 kilograms increases the risk of knee osteoarthritis by 30%, because the load multiplies several times with each step. Inside the joint, cartilage loses water, the synovial fluid thickens, and muscles weaken, making things worse. Diagnosis is clinical and radiological. The X-ray shows joint space narrowing, osteophytes, and bone thickening. Blood tests are usually normal, which distinguishes it from rheumatoid arthritis, where inflammation markers are high. Treatment aims to reduce pain, protect the joint, and slow progression. The foundation is weight control and exercise. Losing just 5 to 10% of body weight can cut knee pain by half. Gentle, low-impact exercise like swimming or cycling strengthens muscles and supports joints. Physiotherapy, stretching, and heat or water therapy improve movement. Cold compresses after exertion reduce inflammation. Among medicines, non-steroidal anti-inflammatory drugs such as ibuprofen, 200 to 400 mg, or diclofenac, 50 mg, help pain and stiffness. For people with stomach problems, topical gels or patches are safer. Corticosteroid injections provide strong short-term relief but should be used sparingly, not more than 3 to 4 times a year. Hyaluronic acid injections can restore lubrication and reduce friction. Around 60 to 70% of patients report improvement for months. Platelet-rich plasma, PRP, therapy, using the patient's own blood, shows promising results in early disease, pain reduction in up to 60% of cases. Supplements like glucosamine sulfate, 1,500 mg daily, and chondroitin sulfate, 1,200 mg daily, may help protect cartilage, with about 10 to 20% improvement in mild cases. Vitamin D and omega-3 fatty acids lower inflammation. Omega-3s, 1,000 to 2,000 mg EPA plus DHA, can reduce joint inflammation by up to 25%. When pain remains severe, joint replacement surgery restores function and eliminates pain in advanced disease, lasting 15 to 20 years in most patients. Preventing osteoarthritis means protecting joints daily, avoid excessive standing, twisting, and heavy impacts, wear supportive shoes, and keep good posture. Untreated, it leads to deformity, stiffness, muscle atrophy, and falls. Chronic pain can cause depression and social isolation. But when treated early, up to 80% of patients maintain normal life for decades. Another frequent condition people call rheumatism is rheumatoid arthritis, a chronic autoimmune disease where the immune system attacks the joints. It affects about 1% of adults, mostly women 3 times more often than men, often between 30 and 50 years old. Unlike osteoarthritis, it starts with inflammation, not wear. Pain is symmetrical, both sides hurt equally, with morning stiffness over an hour and swelling of wrists, fingers, or knees. The pain improves after movement, the opposite of osteoarthritis. The inflammation thickens the synovial membrane, forming a layer that erodes bone and cartilage. The disease may also involve the lungs, heart, and eyes. The gene HLA-DR4 is present in most patients, and smoking increases risk 2 to 3 times. Blood tests show high CRP and ESR, and antibodies like rheumatoid factor or anti-CCP, the most specific marker, appear early. Without treatment, 60% of patients show joint damage within 2 years, and half lose work capacity in a decade. Modern therapy aims for remission, no active inflammation. The main drugs are methotrexate, 7.5 to 25 mg weekly, with folic acid. If that is not enough, sulfasalazine or hydroxychloroquine are added. This triple therapy stops progression in about 70% of patients. For severe or resistant cases, biologic agents like adalimumab, etanercept, or tocilizumab directly block inflammatory molecules and can stop joint destruction. Corticosteroids relieve symptoms quickly but have long-term side effects like osteoporosis and diabetes, so they are used briefly. Non-steroidal anti-inflammatory drugs ease pain but do not slow disease. Lifestyle corrections, quitting smoking, staying active, balanced diet, reduce flare frequency. Omega-3 fatty acids and vitamin D also lower inflammation by about 20%. With early treatment, most people today reach near normal life expectancy, which was once shorter by up to 10 years. Another disease behind rheumatism is gout, caused by high uric acid levels in the blood. When uric acid exceeds 6.8 mg/dl, it crystallizes inside joints, triggering intense inflammation. About 4% of adults, mostly men over 40, develop it. The attack starts suddenly, often at night, with severe pain, redness, and swelling in the big toe, known as podagra. Alcohol, red meat, and high purine foods increase risk. Repeated attacks can deform joints and damage kidneys, forming urate stones. Diagnosis is confirmed by finding needle-shaped crystals in joint fluid or high blood uric acid. Treatment during an attack includes indomethacin, 50 mg 3 times daily, or colchicine, 1.2 mg, then 0.6 mg an hour later. For prevention, allopurinol, 100 to 300 mg daily, lowers uric acid. Lifestyle changes, less alcohol, meat, and sugar, more hydration, reduce attacks by about 70%. Another common cause of chronic pain is fibromyalgia, not inflammation, but abnormal pain sensitivity in the brain and spinal cord. About 2 to 4% of adults, mostly women, have it. Pain is widespread, constant for months, with fatigue, poor sleep, and brain fog. It often follows stress, trauma, or infection. The joints are normal, and blood tests are normal. Treatment focuses on calming the nervous system, aerobic exercise, sleep regulation, and cognitive behavioral therapy work best. Medications like duloxetine, 30 to 60 mg, or pregabalin, 75 to 150 mg twice daily, reduce pain by about half. Finally, another condition often grouped under rheumatism is systemic lupus erythematosus. It is an autoimmune disease where antibodies attack cell nuclei and DNA. It affects 1 in 1,000 women, mostly between 20 and 40. It can cause fatigue, fever, joint pain, and a butterfly-shaped rash across the cheeks and nose. It can also affect the kidneys, heart, and lungs. The anti-nuclear antibody, ANA, test is positive in 98% of cases, while anti-DNA and anti-SM confirm diagnosis. Treatment includes hydroxychloroquine, 200 to 400 mg daily, which reduces flares and improves survival by almost 50%. During active inflammation, corticosteroids or immunosuppressants like azathioprine or mycophenolate are used. In resistant cases, belimumab, a biologic drug, lowers flare frequency by 30%. Avoiding sun exposure, smoking, and maintaining vitamin D levels stabilize the disease.